And you're going to tell us when you want us to start, يا آلاء.
الاتندي 8 9. خليه كمان كذا شوية يزيد.
Okay.
أوكي تمام. نبدأ.
Assalamu alaikum, everybody. And well, I don't know if it's good morning or good evening. Depends on which part of the world you're at. I'm Mirvat AlAsnag. I'm actually an interventional cardiologist and still hoping to be part of the conversation. When we talk about shock, more often than not, it is a collective decision and a collective management. And I don't think we discuss the role of imaging in helping us manage our patients, whether it's detecting complications that need to be addressed by the interventional cardiologist and the critical care teams, or positioning of the devices, or evaluating patients' LV or RV function in the process of weaning and managing these patients. And we're hoping that the program that Dr. Attar and colleagues have put together today is going to shed some light into that. So I want to thank all our faculty and all our viewers, and just to kind of remind you that we're going to hopefully have these sessions recorded and available for viewing at a later time. And without delaying it any further, I want to turn over to Dr. Attar, who's the head of our interventional imaging working group at the Saudi Arabian Interventional Society. So Rowa, over to you.
All right, thank you, Dr. Mirvat. So welcome, everyone. It's very exciting to have this session today. As Dr. Mirvat just mentioned, the role of imaging in mechanical circulatory supports is really important in managing our patients. And I think there's a lot of gaps that can be covered over the next few hours. So without further delay, I'm going to present our first speaker, which is Ohoud Nasser Asghayr. She is a sonographer from King Fahd Medical City, and she's going to walk us through a practical approach on acquiring images for these type of patients. All right, so Ohoud, without further ado, I'm going to let you go ahead and start.
Is my voice clear? Hello?
I don't see your screen, Ohoud.
My voice is clear?
Maybe a little louder. Okay.
You can hear me now clearly?
Yes, we can hear you.
Assalamu alaikum, everyone. My name is Ohoud Nasser. I'm a senior echocardiography technologist at King Salman Heart Center. My presentation will be about echocardiographic assessment in mechanical circulatory support devices. Brief introduction. It is increasingly utilized mode of therapy in management of advanced heart failure. It is a life-saving in patients who fail to improve or stabilize with inotropes intra-aortic balloon pump mechanical ventilator. Replace some of the mechanical function of the failing heart, improve cardiac output and organ perfusion. Goals will be bridge to transplantation, bridge to recovery, and destination therapy. Types are long-term and short-term. Long-term LVADs and short-term AV ECMO Impella tandem heart and short-term VADs. I'm going to talk about long-term left ventricular assisted device assessment in echocardiography first. It is a long-term surgically implanted intracorporeal LVAD, which is a small device implanted into LV apex and loads LV, pumps blood to the aorta, creating continuous systemic blood flow. 3 FDA-approved LVADs, HeartMate 2, HeartWare, and HeartMate 3. We need to know LVAD anatomy so we can assess it properly in echo. The 3 FDA-approved LVADs have similarities, which is the inflow cannula position, which is positioned in LV apex, outflow graft, which is also in ascending aorta, and all 3 of them have mechanical impeller. The differences is that HVAD or hardware impeller and its housing is implanted within the pericardium, where HeartMate device is implanted below the diaphragm, while HeartMate 3 is a fully magnetically leviated component. The parts float rather than rub together, and it's designed to change router speed every 2 seconds to prevent thrombus formation. First of all, I'm going to talk about outflow cannula assessment. It is grafted to the ascending aorta. Distal part of the outflow cannula can be assessed easily. Color Doppler can be used to find the exact location, and sometimes we will see turbulent flow due to the small cannula. And TEE we can see in this image very clearly, while it's in transthoracic, it's very challenging to find in some patients. We need to do off-axis images so we can find the outflow cannula. Basically, we have to use our imagination on how to get a view so we can find the outflow cannula, follow it. We will use continuous wave Doppler to assess speed through the cannula, and signal should reveal systolic and diastolic waveform. In optimal setting, the normal speed should be 1.5 to 2 meters per second. We can see the difference in Doppler for the 3 types of LVAD. HeartMate 3 have a specific pattern, as I mentioned, that it's changing router speed every 2 to 3 seconds. Outflow cannula could be positioned in descending thoracic aorta and highly calcified ascending aorta, or for patients going through less invasive LVAD implantation. It could be very challenging. Sometimes I remember this patient, it was very difficult to find the outflow cannula, but the LVAD team was with me during the echo, so they pointed to me that it's in the descending thoracic aorta, so it was very challenging to find. You can see here, it is not a regular view. I had to show descending thoracic aorta with the outflow cannula here. You can see it, and took the Doppler also. For the inflow cannula, it is implanted in LV apex, and it should be directed toward mitral valve, as we can see here. For HVAD and hardware VADs, it's challenging to assess the inflow cannula since it can cause a specific artifact in 2D and in color and in Doppler, as we can see here in this image. Can you see my pointer? Okay. Cannula position can be assessed in transthoracic in off-axis images and sometimes in a parasternal long axis view, as we can see here, short axis view, and apical for chamber, which can be very challenging. Doppler will show low diastolic and high systolic velocity. Systolic velocity should be 1.5 meter per second, less than 1.5 meter per second. High systolic velocity can indicate flow obstruction. Diastolic velocity is important in a good functioning continuous flow LVADs. Doppler evaluation of inflow and mitral inflow pattern in patients of HVAD, as I mentioned before, it will be limited due to waterfall artifact, as we can see here in this Doppler. I will show you how to avoid it. HeartMate 3 device is programmed to change router speed, as I mentioned before, so we can see specific Doppler images for HeartMate 3. Inflow cannula can be positioned in a different way, like in this case. This patient with hypertrophic restrictive cardiomyopathy, the inflow cannula was in LA due to small cavity of LV. So the inflow cannula has changed. We can see here very beautiful 3D image. Doppler signal adjustments. Sometimes we will see this kind of artifact, mostly in inflow cannula, because of the motor could be in the way of the continuous wave signals. So we have to try to take it from a different angle so the motor will not be in place. Actually, we cannot see the motor, but we can see the cannula. So we will try to position our cursor in a perpendicular way. So we will avoid this artifact, as we can see here, after adjusting the cursor. This is the same patient, but this one for a different, this is for chamber view. And this is in parasternal long axis view. As you can see, the different on the view, so I can get it without artifact. This is a waterfall artifact, as I mentioned before, in HVAD patients. We need to take the Doppler from the graft distal to the inflow cannula. So we will follow the inflow cannula until we will see a clear color Doppler without the turbulent. So we can get an accurate Doppler wave, as we can see here in this image. This is not accurate. I saw some ecotechnician measure the velocity from this artifact, which is not correct at all. We need to follow the cannula and avoid the artifact. If we see good color Doppler, we will take the pulse wave Doppler from it. Left ventricle and interventricular septum position. Effective unloading will reduce LV size, and measurement of LV volume and LV ejection fraction can be technically difficult for patient post-LVAD implantation, especially the apical four-chamber view is very difficult post-implantation. LVEF need to be obtained with biplane Simpson method, as we can see here in this image. The septum position, we should take a four-chamber image with 5 beats, so the doctor can appreciate the motion of the ventricle septum with long beats. Evaluation of interventricular septum position is important. It should be central in position, as we can see here in this diagram. Poor unloading will cause septum to shift to right side, and LV will be dilated, and excessive loading will cause the septum to shift to left side and disrupt right side function. We can see here a very dilated LV and septum pushing to the right side. A contrast used in LVAD, I read this research published in European Society in 2018. They used contrast on HeartMate 3 LVAD patients, and they stated it's safely used and it didn't change the function of the VAD. We can see here in this image, it is very helpful to use contrast to visualize LV size and compare it to right side. It is very beneficial in assessing with patients with very difficult apical views. And also it can be used to detect LV apical thrombus. As we can see in this case, it was next to the inflow cannula. Using contrast was very helpful in diagnosing this. We didn't use contrast in our center. Hopefully we can use it for LVAD patient. For aortic valve opening should be assessed with M mode, as we can see here in this image. Ideally, aortic valve should open every 2 to 3 beats, and opening is in every beat could be suggestive of insufficient unloading. And if it's consistently closed valve, it will suggest excessive unloading. We need to take 2D images like this with a long duration so the doctor can appreciate the opening and closure with the mode also. Aortic valve should be assessed for the severity of AR. Presence of AR will reduce the effectiveness of forward LVAD flow, as we can see here. It will cause valve VAD re-entry. Leaflet deterioration will happen if the valve is consistently closed, and we can see thrombus formation here and severe AI due to destructed leaflets. For mitral valve, MR often present pre-LVAD implantation. Reduction in LV size post-LVAD implantation should improve mitral valve coaptation and reduce mitral annular size, which in advance will reduce MR or make it better. The presence of moderate to severe MR might indicate insufficient unloading. Assessing MR is difficult in patients with HVAD, as I mentioned before. We can see here in this diagram, in this image, this is a patient with moderate to severe MR. After incrementing the speed, it improved. For RV function, most important determinant of successful LVAD support is a good function in RV. RV failure occurs up to 40% of cases. 10 to 25 will need RV support. LVAD will unload LV, but also will load RV. It is important to find an optimal balance load in both ventricles. Patients with RV failure due to left-sided disease will perform better after LVAD implantation. RV systolic function should be assessed properly in pre and post LVAD echoes, and all the measurements should be taken. LVAD speed optimization scan, it is generally performed with asymptomatic and minimally symptomatic patients, consists of a baseline images with a baseline speed, then the images after incrementing the speed. Speed should be annotated in every image. At each new speed, the following images should be taken: LVEF, interventricular septum position, aortic valve opening, frequency and duration, MR and TR severity. In optimum LVAD setting, interventricular septum should be centered in position, aortic valve opening every 2 to 3 beats, and no more than mild MR. Complications, first is tamponade. This is the image post-operative. LVAD physiology lead to lower pressure in left side, so the fluid or blood will accumulate at the level of LA near to the LV, where RV remains unaffected, as you can see here in this image. LVAD thrombosis, low flow alarm, presence of thrombus in pump with severe heart failure symptoms. Color Doppler of inflow cannula will show turbulent or backward flow. The inflow velocity will be more than 2 meters per second, as we can see here in this Doppler. Outflow will be very difficult to find, as we can see here, almost not there in flow cannula. We cannot see the Doppler. Suction events, we can see here in this image. This is post-implantation directly. Speed was 2,400. After decreasing the speed, LV become better. I'm going to talk about short term, but I'm not sure if my time is enough. About impella and temporary VADs.
Thank you, Ohoud. Yeah, I think we're gonna go a little over time. So why don't we stop here?
Okay.
Thank you so much. It was really an excellent talk. So I'm gonna get Dr. Ahmad AlMustafa to basically present our next speaker.
Assalamu alaikum jamian. Good evening, everyone. Thank you, Dr. Rowa Attar, for putting all this together, and thank you for the invitation. Our next speaker is Dr. Fahmy Al Kaf. He's a consultant cardiologist at King Fahd Medical City, and he will be talking about intraoperative, intraprocedural echo for left ventricular support devices. Dr. Fahmy, the floor is yours.
Thank you, Dr. Ahmed. Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Ahmed, and thank you for many thanks for all of organizer of this webinar. Today, inshallah, I'm talking about the echocardiography assessment of the LVAD patient. I'm trying in this next 20 minutes to address most of these items like introduction, peri and post LVAD implantation, and we'll talk about some specific consideration and application if we have time, inshallah. First of all, as you know, if heart failure patient, especially with reduced ejection fraction, after all these tips of management and optimize medically and device, and after all that, still he's severely symptomatic, this is what we call him stage D heart failure. And stage D heart failure, we have two options mainly, durable VAD, LVAD, or transplantation. For LVAD, currently, currently, we have in the market the only FDA approval in the last 2-3 years, the HeartMate 3, and have FDA approval since 2014. This is the LVAD, just summarize. I will summarize it here for the people. LVAD is like artificial left ventricular heart, is going to assist the left ventricle by taking the blood from the left ventricle, especially with severe reduced ejection fraction, and take the blood from the LV to the aorta. So we try to bypass the LV and get at least 70 to 80% of the job of the left ventricle. LVAD have many parts. Start from the inflow cannula, and this is the part of the LVAD what will be implanted inside the left ventricle, and we can see it in the echo. And it will take the blood from the left ventricle, then it will push it to the pump here, and the pump had the impeller which will be outside in the pericardium, outside the LV, on the apex of the LV exactly. It will push the blood to the outside of the heart, to the aorta, especially the ascending aorta. For assessment pre-LVAD implantation, actually we need to, as usual, we need to do the comprehensive routine assessment as any patient going for the surgery. But there's something we call it red flag finding for the patient who's going for, especially he's going for the LVAD. And this red flag should be taken careful during the reporting of the echo for the heart failure or for the cardiac surgery, especially if the indication is the advanced heart failure for the LVAD. And first of all, we need to assess the left ventricle and the red flag assessment for the LV, like small LV, and by guideline LV end diastolic dimension less than 63 millimeter is getting some risk of morbidity and mortality, especially in 30 days after the implantation. Also, you need to assess the site where we will implant the device in the apex of the LV for any thrombus or apical aneurysm or thin myocardial wall. Also, be careful to assess any shunt, not only the VSD as mentioned here, even the atrial ASD or BFO. And the reason of that, this shunt after LVAD can be reversed, even if it's small and from left to right, and no problem from it, but can be reversed. And the reason of that, after the LVAD implantation, as I tell you, this is most of the work will go through the LVAD. So the pressure in the LV, this is our target, decrease the pressure in the left ventricle, and decrease significant pressure in the LV can cause reverse the shunt, as the RV pressure may be more higher than the LV now. So the shunt will be reversed from the right to left, and this will carry risk for the patient to be desatting in the intraoperative or difficult extubation due to desatting, as this is now deoxygenated blood in the ICU. So be careful to assess any shunt here and need to be fixed during the OR. It's not contraindication, need to be fixed in the OR during the implantation. Other as we need to assess properly for RV dilatation and function, and it's very important here to assess also the atrium for any appendage thrombus or any defect as BF4 septal defect. for valvular abnormalities, it's very important to know about the aortic regurg, and aortic regurg, especially more than mild, moderate, or severe, usually need to be fixed during the OR surgery. Other mitral stenosis, not MR. Other valve like tricuspid regurg, TS or BR need to be, especially if more than mild, need to be discussed before the implantation for possible fixation during the surgery also. Other findings like congenital mass or any other shunt. Then during the implantation in the OR, initially you need to again to reassess any red flag finding in the OR during the TE before the surgery. And then you will go for the first step, localization of the inflow cannula position. And the inflow cannula position you can see here, for example, sorry, this is not the cannula, this is the finger of our cardiac surgeon. He's pushing by his finger the apical of the LV from outside to the inside the cavity, and by this maneuver he can localize the best position to implant the cannula, and the best position from the apex to mitral valve, not to the lateral or to the aortic valve. Then after implantation, you need to re-evaluate here, and you can see in the left side image the proper position of the inflow cannula to the mitral valve. But unfortunately, and this is not avoidable, after implantation, you will have some angulation in some of the patient, and the reason that means angulation of the cannula to the lateral wall or to the septum. And this is mild angulation is acceptable usually. The main reason of that, the LV was severely dilated before implantation when we are localizing the apical position. And after LVAD, the LV will be shrink slightly in the side, which can change the direction slightly. Usually with mild angulation, it can be acceptable usually. Also, 3D can help you in the assessing the position. Then you need to assess the inflow cannula function. And the function starts with the color Doppler here. As you see, there is no significant turbulence. And also by the Doppler, by CW or BW, to see the maximum velocity through the inflow cannula. And the for heart made 3, the acceptable velocity maximum to be less than 2 meters per second. Then you will assess in the outflow cannula by the again color Doppler, and to assess the velocity also in the ascending aorta. And be careful, after closure of the chest, please re-evaluate the patient again and repeat all things, especially assessing the inflow outflow cannula. And due to the after closure of the chest, this can change the orientation of the inflow and outflow cannula. So maybe you have some change acceptable, but if the significant position change, maybe to inform the surgeon for possible re-exploration. This is one of our patients. He's 20 years old male. He's post LVAD, and they call you for low flow alarm. And you ask for echo, and this is the image what we done for the patient. What's this? So what you will do here, just you will do not change, or you think this is as low flow, this is low hypophilemia, and you need to give the patient some volume, or this is what we call it suction event, and now we need to decrease the speed, LVAD speed rapidly, slightly, I mean. Or this is RV failure, need RVAD. And you can see here in the short axis of the mid LV cavity, how is the LV small in size and D-shaped, and RV is dilated. And you can see in the short axis here in the apical of the LV. You see this is the ring, white ring here. This is the inflow cannula, and you can see how is the inflow cannula is almost partially occluded by the LV cavity, and this is what we call it suction event, when the for other reasons like speed of the LVAD is high or RV failure, the LV cavity getting small and partially or totally occluding the LV cavity, and this is suction event. And you need here urgently, you need to increase the LVAD speed to give some volume in the LV, and getting it back to be dilated, and get the wall away from our inflow cannula. So decrease the field. And let me give you some information about this, what we are doing actually in the heart failure. This is during the decompensation or advanced heart failure. As we know, the LV, we call it loaded LV. Loaded LV, that means the pressure and volume in the left ventricle is significantly high. This will be reflected in the lung by congestion and by the aorta to the body by decrease the cardiac output. So what we are doing in the LVAD, actually after implantation, this is our target to unload the LV. Unload LV, that's mean your target to some target, you need to decrease the pressure and volume of the LV to acceptable normal range and improve the cardiac output. So what the question, this is fixed speed of the LVAD. So if the speed, we fix the speed on higher speed, much what the LV need, this one can lead with the time decrease the LV size until be closed the LV and closing the our inflow canal, what we call suction event. Or in the other way, maybe our speed is very low, patient don't get big benefit from the LVAD, and the pressure in the LV will be still, and volume pressure, the pressure and the volume LV will be still high, patient will still have congested. So how will optimize the speed? How will select our speed from the echo point? So optimizing the LV speed actually started from the LVAD, during the OR, during the implantation, when we are run the pump after the implantation, and during the ICU and ward, and even after the follow-up with the clinical appointment. So the most three important steps to assess the optimal speed in the LVAD is first start from the position of the interventricular septum, aortic valve opening, and the other most important like the dimension of LV and RV. Let me give you some hint about the septum position here, and you can see here in this image, if we have proper unload, as we mentioned in the previous slide, unload of the LV with good acceptable pressure in the LV and volume acceptable in the LV, that means the septum will be in the middle, and this is our target. But if the pressure, and we do good unload for the LV and the pressure and the LV still, well, volume of LV is still high, this pressure and volume again, like in any heart failure before the LVAD, will be push the septum to the right, like in this case. And here you need usually to increase the speed of the LVAD. On the other hand, if the speed is too much and more than what the LV need and more than what the RV can tolerate the volume, so this will lead to significant drop the pressure and volume of the LV, and with the time LV will be decreased in the size and septum will be shifted to the left, and at this point usually you need to decrease speed, otherwise you will have suction event, as the example we mentioned in the question before. Other aortic valve opening, that means again, if we have good unload of the LV, that means we take almost 70% of the job of the LV. So aortic valve cannot be open every beat, and this is our target. Actually need to accumulate more volume every 2 to 3 beats here in the LV to push the blood to can be open the aortic valve, and this is our target actually to make the LV aortic valve is open every 2 to 3 beats, not every beat. But if we have, and actually need mode here for proper assessment, due to sometimes it's not clear in the 2D image due to the usually maybe the aortic valve is not open totally, is faintly open. So we need a mode here to assess properly aortic valve opening. And if, for example, like this patient is totally closed aortic valve is not open, that means maybe the speed of the LVAD is more than the patient he need, and you need to decrease the speed here. Or the other hand, if it's open every other beat, maybe the speed is higher, more than the patient he need, I need to increase it a little bit. And our target, don't forget, is aortic valve to be open every 2 to 3 beats. Other measurement like the LV size and dimension, and RV size dimension, and mitral regurg, aortic, pulmonary artery pressure, tricuspid regurg. All this measurement we expect to improve significantly after LVAD implantation. This is 51 years old male. He is ischemic cardiomyopathy post LVAD implantation. So just test here what we present in the previous slide. What you will do here, you can see in the left image, the aortic valve is totally not open. So we decrease the speed here. So the aortic valve now is open every beat. So this is a 55 years old male. He's post LVAD. He's asymptomatic, and we do assessment for the inflow cannula speed by the CW Doppler. So from this image, what you have here, the inflow cannula CW, which one represents the maximum systolic inflow velocity, A, B, or C? And let me explain to you what happened here. Actually, the LVAD is continuous flow. That means it will take the blood during the systole and diastole. So the diastolic here, this is A, will have flow. But during the systole, due to the contractility this of the LV, this flow will be augmented also. So we'll have increased the speed during the systole. There is diastole flow and augmented during the systole. And here usually we need to measure the velocity. But what we have here in DC, this is what we call it new advanced technology in the LVAD to decrease the thrombosis of the LVAD, something we call artificial pulse. And as Ohoud mentioned, in the previous presentation, this artificial pulse will happen every 2 seconds. And let me explain to you exactly what will happen. Actually, the LVAD now, it will change the speed, fixed speed. For example, if on some number, we change every 2 seconds, we go down 2,000 lower, then 2,000 higher, what you fix. And this is only happen for almost 0.35 seconds for every 2 seconds. And let me give you an example. If we fix the speed for 5,000, for example, the every 2 seconds speed will go down to this is 5,000, this is flow. The speed every 2 seconds will go to 3,000 here. So the LV will be filled, and you see the flow through the LVAD here is drop. This is due to the speed. This technology is decreasing the speed here, so the flow through the LVAD is decreased, and this to get the LV slightly to fill, and then the speed will be increased 2,000 more than our baseline. So to 7,000, this will lead like a gush of blood to minimize any thrombosis in the LVAD. And we will be reflect here in the CW, and be careful when you assess the systolic flow to avoid at least the artificial pulse. And you can see artificial pulse in the A line, but you cannot detect it in the clinically. And this is again what we have in the previous examination. So this is 61 years old male, post LVAD. He has shortness of breath. So what's the problem here? This turbulence of the image here, what you see is due to the pump failure, or due to thrombosis, or due to male position, or this is artifact. As Ohoud mentioned in the previous presentation, this is artifact actually. Let me explain why we have this artifact in the LVAD, especially HVAD and HeartMate 3. And previously we have HeartMate 2, almost 20, was started to be in 2000. 24 years ago, we have HeartMate 2, and HeartMate 2 was axial. That means the blood will go from the same line, inflow and the outflow, the same line. This is axial flow pump. And actually was implanted intra-abdominally. And the reason of that, you can see the cannula is not the same line in the pump. Here the pump, and this is the inflow cannula. So it's not in the same line, but was great idea for heart failure and for cardiac arrest to change this one to something we call it in HVAD and HeartMate 3. It's something we call it centrifugal. That means the pump will go, the flow will go in the one direction and go to 90 degree from the other direction. Now that we have smaller pump, can be implanted totally intra-pericardium in the chest. It's great for us, but maybe, and we have also magnetic here or maglev pump. We are happy actually in heart failure and cardiac surgery. So now is less complication, mainly implanted small device implanted in the chest, but in the echo we have the problem with more artifact. And the main reason of that, the inflow cannula now, the inflow and the pump itself, the impeller, all in the same direction of our Doppler. You can see here the line of the Doppler, the same. The line of the going with the inflow cannula going to the pumps. So the pump here with the impeller inside, all this can give us the artifact. So this is now specific consideration for centrifugal LVAD. You will have many artifacts, as here mentioned here, and you can see here. This is artifact, and the main problem will give you zoom image on the inflow cannula, for example, and maybe you will be confused. This is turbulence, considering malfunction, thrombosis, or this is artifact. And Ohoud, as she mentioned, maybe you just need to go slightly off axis by the rotation of the probe away slightly from the pump itself, which can help you to avoid this artifact. And you can see also the artifact in the also CW, the same problem, and
Dr.
here
Fahmy,
also. Yes.
I just want to remind you about the time. We're almost like approaching your end of time, like 7:40. How many minutes do you think you need?
I need 5 minutes if you don't mind.
Okay, that's fine.
So again here, this is an artifact also can assist the inflow canal with the same problem. If it's difficult to assist the inflow, maybe you go to the outflow canal and will be probably assessment. Here, this is again another artifact. We call it artifact shadowing. And now it's not from the pump, and you can't see it here in this question. And mainly this artifact coming from not the pump itself, it's coming from the something we call it apical ring. Apical ring here, this is ring will be sutured to the apex, then the pump itself will be locked in this ring. And actually this ring can give you some shadowing artifact, and maybe sometimes you will be confused, especially immediately first day post CIG, you will be confused if this is hematoma or no, but actually just this is artifact. So this is 59 years old male, post LVAD or HVAD. He's asymptomatic. So what's this aortic regurg? It's mild, moderate, severe, or we need further image. Actually, for me, even me, I don't know. You can see one image is mild, one image is severe, one image here is continuous. So this is what's the problem in the of aortic insufficiency aortic regurg during the or after implantation. Actually, the main two problem after of the assessing of aortic regurg post LVAD, especially the continuity of aortic regurg, especially if totally closed LVAD. That means the aortic regurg now is not during the diastole, it's during the systole and diastole. The other thing, the variability of this aortic regurg, and the variability actually could be due to the pump speed difference, and actually the aortic regurg now can be changed even with the hemodynamic change in the parameter. For example, you will do echo with for the patient with high MAP, for example, and you see the aortic regurg is significant. And after a while, patient maybe will take his medication or they control the Hertz MAP, and you will repeat, you will find no, it's less now, it's not severe. So this is variability is making difficult to assess the aortic regurg actually. And you need, usually it's better to be, aortic regurg can be intermittent, especially if aortic regurg is still open, or predominantly diastolic and near continuous, or could be continuous, whole systole and whole diastole. And usually you need to proper assessment to do color M mode and CWWR. Actually, for guideline to 2015 of AAC guideline for assessing the aortic regurg, they recommend to assess by the severity, especially if moderate or more, that means significant, and vena contracta if point equal or more 0.3, or the JIT to width to LVOT width is more than 46%. And please don't use the pressure half time, the Doppler, to assess the AI due to the after the LVAD. And the main reason of that, the AI duration now extend to systole, and this is highly affected by the LV preload, afterload, and aortic pulse pressure with dimension during the LVAD support. This is new measurement of aortic insufficiency. We call it peak systole to diastole velocity ratio of outflow graft. That means we assess the systole like this. This is the S point here, and diastole, and the change or the difference between these two is getting decreased. That means AR is severe. The other, if we need the diastolic acceleration of outflow cannula, this is the line acceleration from the start of diastole, the acceleration to the end of the diastole. If it's significantly high, that means AR is severe. We have more time, Dr. Ahmed? Or?
You have like 1 minute more.
Let me finish this slide.
Okay.
Actually, in heart failure, we like to connect everything to the hemodynamic, actually, to understand why we use this like systole to diastole index or acceleration of the diastole time. Normally, like this in hemodynamic, you can see this is the aorta and this is the LV, and during the hemodynamic scale. And you can see here the diastole, the filling of the LV during the diastole is smoothly here, slightly going up the pressure of the LV gently here during the diastole. But in the aortic regurg, you can see due to the LV filled now from significantly from the aorta through the aortic regurg and from the atrium. This would lead to the rapid and acute filling of the LV with increase the LV and diastolic pressure here. And this can be assessed in the LVAD through the echo, through the assessing the outflow cannula here. You can see, and normally like this, like in the hemodynamic, you can see the smooth filling of the LV during the different systole and diastolic pressure is still low here. But in the significant aortic regurg, you can see here the same in hemodynamic. This is the filling of the LV is getting acutely rapid here with end of diastolic pressure is significantly increased, and difference between systole and diastole is significantly increased, and the same in hemodynamic actually. And this is the actually test this new parameters is tested in some studies and showed is good correlation to the pulmonary wedge pressure of hemodynamic more than our routine traditional assessment of aortic regurg. Thank you.
Thank you so much,
Thank you,
Dr. Fahmy. يعطيك العافية. Thank you.
Thank you, Dr. Fahmy, for really a very comprehensive and a very excellent talk. I certainly learned a lot from it. But just due to our time limits, we're going to have to move to our next speaker. So our next speaker is going to be Dr. Raymond Stainback. Thank you so much for joining us. So Dr. Raymond Stainback is the past president of the American Society of Echocardiography, and he's also one of the chairs for the ASC guideline that was published on assessment of echocardiographic imaging post-mechanical circulatory support assessment, or particularly LVAD. And he has, I guess, a special interest in this area. He's also professor of medicine at Baylor College of Medicine. So Dr. Stainback, if you want to go ahead and share your screen.
Okay, thank you for that introduction. And I just wanted to say two things after the prior talks. I'm glad that our prior speaker talked about the aortic regurgitation there at the end in a great way, that new measurement. It's really, there's two Achilles heels for LVADs, and one is RV dysfunction and one is AR. So that's one thing I've learned over these years. Now, my talk is on RVADs, and I did this talk that I'm going to show you today a few years ago, actually, because the guideline didn't cover RVADs. Our guideline is going to be updated in August, and so what we'll cover here today is going to be on there. So I'll go ahead and try to share my screen if possible, and hopefully you can hear the sound. This is actually going to be recorded, so hopefully it'll stay within the time limit. Okay. Here we go. Hello, I'm Dr. Raymond Stainback, Chief of Non-Invasive Cardiology at the Texas Heart Institute in Houston, Texas. It is my pleasure to discuss echocardiographic guidance and assessment of right ventricular assist devices. I have no relevant disclosures. I had the pleasure of chairing the 2015 ASE guideline on the use of echo for left ventricular assist devices, which was relatively silent on recommendations for BiVAD and RVAD support. This August, the ASE will publish a long-awaited updated mechanical circulatory support guideline that includes the different forms of temporary mechanical circulatory support, including for the RV, and it will nicely summarize much of what is covered in today's lecture. Today's goals include a brief survey of recent literature that argues for an improved knowledge base and new imaging skills for sonographers and echo doctors who may find themselves on the receiving end, so to speak, after invasive cardiologists or cardiovascular surgeons and anesthesiologists have already set the stage in an emergency situation and then request serial echo evaluations. I have found confusion among sonographers when it comes to the term extracorporeal membrane oxygenation, or ECMO, which may or may not be synonymous with direct or indirect RV mechanical support.
I will spend some time differentiating veno-venous versus veno-arterial ECMO support and non-ECMO RVAD mechanical support. Each RV support system will be correlated with real cases that will be used to examine strategies for better organizing scanning protocols and presentations. And finally, I will touch on echo-based device parameters. In 2017, Victorian Life Support Association reported a staggering increase in V8 ECMO cases from 2002 to 2012, with a consistent survival rate of 45 to 50%. The latest 2019 ELSO report indicates up to 100,000 patients treated at 500 centers, although this includes a mixed population of patients. Nonetheless, this reflects a large increased usage seen at many programs in recent years. This recent position paper by ECMONet and ELSO listed non-invasive cardiology with ability to perform urgent TTE and TEE as a necessary component of the extensive multidisciplinary ECMO center team. This 2012 ASE state-of-the-art review indicates the need for imaging at implantation when possible, for surveillance to examine response to therapy and complication detection, and to help assess decannulation prospects. Whenever an echo order is received, the echo team should become knowledgeable in the patient's phase of care, the device type, and whether or not there are specific diagnoses or complications that are under consideration, and whether appropriate parameters related to device weaning should be obtained. The three device types will be veno-venous ECMO, providing primarily respiratory support, veno-arterial ECMO, providing respiratory and circulatory support, and thirdly, what I will call venopulmonary direct RV support that can be used with or without extracorporeal membrane oxygenation. Veno-venous ECMO is used when respiratory failure has progressed to the point of toxic mechanical ventilator settings. A percutaneously placed jugular or femoral vein inflow cannula is advanced to a position near the right atrium. Systemic venous blood is withdrawn and pumped through an extracorporeal membrane oxygenator and onward through a secondary return femoral or jugular vein cannula to deliver blood back to the right atrium. This oxygenated blood is then pumped to the pulmonary artery using the patient's own native RV function. Improved pulmonary oxygenation lowers pulmonary vascular resistance, and improved arterial oxygenation lowers left ventricular filling pressures, which provides a salutary effect on RV function, even though mechanical RV support is technically not provided. Three most common VV ECMO configurations are femoral-femoral, femoral-jugular, and jugular vein dual lumen cannula, known commercially as the Avalon. I recommend that sonographers annotate VV ECMO and the cannula configuration on the imaging screen. Please note that the dual lumen cannula can be more subject to complications and has higher imaging needs during insertion and surveillance exams. For femoral-femoral VV ECMO, the inflow cannula tip should be several centimeters below the IVC-RE junction, and this may not be visible by echo. The return cannula tip should be slightly into the right atrium as shown on figure B in the middle, and the echo image on the right, which shows flow emanating from the return catheter side ports. Please note the screen annotation in yellow, VV ECMO FEM to facilitate study interpretation. When the inflow and return cannulas are too close together, as in image A on the left, this can result in what is called recirculation. The inflow cannula entrains already oxygenated blood back into the system, reducing the overall forward flow. Recirculation can usually be evidenced by device controller readings, but cannula proximity may be evident by echo at the time of cannula insertion. This 57-year-old man required VV ECMO for respiratory failure from COVID-19 related ARDS. An echo was requested to evaluate unexplained hypotension. Before imaging a patient, a first step is the chart review and, whenever possible, discussion with care providers to confirm device type, phase of care, and reason for exam. Here we see the VV ECMO controller, an extracorporeal centrifugal pump, the oxygenator, and the femoral access sites. The patient is COVID positive, and the ASE has made recommendations for imaging provider exposure safety. This figure illustrates the VV ECMO femoral jugular configuration. In our lab, we would annotate VV ECMO FEM IJ on the screen. The inflow cannula tip is positioned within the inferior vena cava, and the return outflow cannula is within the superior vena cava with the tip near the SVC-RA junction, so that returned oxygenated blood can flow across the tricuspid valve and into the RV, instead of being entrained back into the inflow cannula, as illustrated by the small lower red arrow. If the catheter tips are too close, recirculation can occur. The use of TTE or TEE, right atrial views at the time of cannula insertion, can be useful to avoid the situation. The final VV ECMO configuration is the internal jugular dual lumen single cannula or Avalon Elite cannula. This device has the advantages of lower infection risk and the potential for patient mobility. The design incorporates a proximal and distal inflow lumen, illustrated by the blue arrows, and a separate internal outflow lumen with an outflow port that should enter the right atrium, is indicated by the red arrow. TEE has been recommended for guiding cannula insertion into the IVC and confirmation of outflow port position. With fluoroscopic imaging alone, the distal cannula, including the guide wire and obturator, has the potential to cause any of the complications listed in blue. These surveillance TTE images of an Avalon cannula are also from a patient with COVID-19 ARDS who underwent ECMO support. The transthoracic images on the right show normal apical and subcostal four-chamber views to indicate a complete surface exam is possible. The important view is a sweeping recording of a modified subcostal view confirming the IVC position and the right atrial location of the outflow port. Although the outflow port may be slightly distal near the IVC, repositioning was not needed due to normal flows and no recirculation. We are now ready to discuss imaging for the big guns of RV support, so to speak, starting with VA ECMO. Because rapid percutaneous deployment is possible, peripheral VA ECMO can rapidly be deployed in the setting of Intermax Level 1 crash and burn cardiogenic shock type scenarios. Our first VA ECMO case involves a 68-year-old male who experienced VT-VF arrest in the ER, where he presented with new acute heart failure 12 days after bypass surgery. After resuscitation, TTE, and subsequently a CT angio exam diagnosed a large post-infarct VSD and subacute closure of 2 bypass grafts. The patient was initially stabilized with a tandem heart left-sided percutaneous VAD. After percutaneous VSD closure in the cath lab, he was transitioned to peripheral VA ECMO and a left-sided Impella device. Here we see an illustration of the percutaneous tandem heart device initially used for LV unloading, which also helped reduce the VSD shunt. The figure on the left by Dr. Kapoor and Associates indicates the peripheral VA ECMO cannulation configuration used in this patient, which included a left internal jugular vein inflow cannula and an outflow femoral artery return cannulation site. Because VA ECMO dramatically raises LV afterload, the Impella 5.0 was used to assist the left ventricular function. After several days of biventricular support, a DEE was ordered to further evaluate a failure to wean from mechanical support. Here we see an appropriately positioned Impella device, which is also annotated on the screen, along with an annotation of the VA ECMO configuration. Despite good Impella positioning and flows, there is no aortic valve opening on significant inotropic support, indicating poor LV contractility. The four-chamber TE view on the left of the screen shows an adequately positioned VSD closure device. The VA ECMO inflow cannula can be seen on a modified bicaval view in the superior vena cava on the right side of the screen. During a VA ECMO turn-down study from 3 to 2 to 1.5 liters per minute flow, the RV demonstrated no enlargement, decrease in contractility, or the development of significant tricuspid regurgitation, even though there appears to be some residual VSD shunting through the closure device. However, the patient remained Impella dependent even after VA ECMO was successfully decannulated. Unfortunately, the patient ultimately died after declining durable surgical LVAD implantation. Our next case of VA ECMO involves a 34-year-old male who underwent very high-risk third redo chest surgery for attempted repair of recurrent aortic prosthesis endocarditis and severe aortic regurgitation. He underwent aortic root homograft placement, coronary bypass surgery, and sternal wound debridement. Unfortunately, he could not be weaned from cardiopulmonary bypass, so central VA ECMO was implemented in the operating room using femoral vein and central axillary artery cannulation. An intra-aortic balloon pump was empirically placed for LV support. On post-op day number 2, a TEE was ordered to further assess RV and LV function with high IV inotropic support needed to maintain systemic blood pressure. Even in this challenging post-op setting, a problem-focused TTE was very useful to show a dilated, severely hypokinetic left ventricle with minimal aortic valve cuts separation, but with good RV unloading by VA ECMO. The ultrasound enhancing agent exam on the right side of the screen further confirms severely decreased LV systolic function and the presence of left ventricular sludge versus thrombus. There is a small body of literature to support the use of ultrasound enhancing agents during ECMO and LVAD support. This study powerfully illustrates the fact that an intra-aortic balloon pump is often insufficient to support a dysfunctional left ventricle in the setting of VA ECMO support. We will now turn our attention to the various forms of direct RV support. Whereas the VA ECMO systems provided indirect RV support by unloading the RV and directing oxygenated blood towards the arterial system, effectively bypassing the RV, the Impella RP, right tandem heart type devices, and surgical RVAD strategies directly pump blood into the pulmonary artery to directly assist native RV function with or without oxygenation. An extracorporeal membrane oxygenator can be added into the circuit if needed, except for the Impella RP. And this is sometimes referred to as oxy-RVAD support as opposed to ECMO. A careful chart review reveals a history of complex congenital heart disease in a 42-year-old woman with very high risk for third redo surgery for replacement of pannus-obstructed mitral and aortic mechanical prosthetic valves. Following cardiopulmonary bypass, the patient required VA ECMO and balloon pump for transient RV dysfunction. VA ECMO and the balloon pump were decannulated on post-op day number 4 successfully. On post-op day number 6, recurrent RV failure was diagnosed, and Impella RP was placed percutaneously as a further bridge to recovery. Even in the setting of recent cardiac surgery, the TTE was adequate in this case for evaluation of biventricular function and Impella RP position and function. In the upper left image, the cannula inflow region is visualized near the IVC-RA junction, and parasternal short-axis views of the RV outflow tract nicely show that the outflow zone is very close to the pulmonary valve, although flows and apparent RV support are good. The image on the right illustrates some optimization of the outflow zone position more towards the pulmonary trunk during repositioning. A 67-year-old man required durable surgical LVAD for destination therapy after a long and complex history of left-sided heart failure. After LVAD implantation, VA ECMO was required for RV support following LVAD activation in the operating room. After a storming postoperative course including incessant VT, VA ECMO was later replaced with a ProTech Duo RVAD device for ongoing RVAD support, and this led to improved mean arterial pressure and improved LVAD flows, presumably by removing the high LV afterload associated with VA ECMO. A TEE was ordered to assess biventricular support on ProTech Duo. The figure on the left illustrates this patient's HVAD device, and on the right are illustrations of the ProTech Duo dual lumen single cannula device. This device is similar to a right-sided tandem heart configuration, but instead of using two separate cannulas, right atrial systemic venous blood is withdrawn from a proximal port to be received by the extracorporeal centrifugal pump and then delivered distally through a distal outflow port. Remember, this design is analogous to the dual lumen single cannula Avalon VV ECMO device that we previously saw. In this case, however, hemodynamic support is provided without the need for oxygenation in this case. Therefore, this is not ECMO, but direct RV hemodynamic support. The TEE images on the right demonstrate a nearly balanced ventricular septal position and continuously open mitral valve bioprosthesis due to marked LV unloading from the HVAD, which is ensuring adequate forward flow to the right ventricle, which is then not experiencing distension by virtue of relatively balanced continuous ProTech Duo RVAD support. The three-dimensional TEE image on the lower right shows partial RVAD cannula visualization and the RV outflow tract area. The upper TEE image on the left shows the proximal RVAD cannula's superior vena cava position using a bicable view. The center image of the aortic valve in short axis demonstrates no aortic valve opening consistent with LVAD support. Color flow Doppler in the left lower image of the pulmonary trunk shows the distal RVAD cannula's effluent jet washing the continuously closed pulmonary valve cusps consistent with RVAD support. Please notice that the type of BiVAD support and sequence of altered pump speeds during the exam are annotated on the screen. Time does not allow us to cover the many other combinations and configurations of RV support. The VA ECMO weaning parameters, which are currently based on small studies, lack broad consensus but are summarized on this table. In most cases, VA ECMO weaning is unlikely to occur until after day 3. In some facilities, a daily ECMO surveillance program is in place to determine patient's trajectory. Here are some final basic scanning pointers that may help improve your image presentations. It's been a pleasure speaking with you today. Thank you for your attention.
Thank you, Dr. Stainback. It was an excellent, elegant presentation. I just want to remind the audience, the attendees, to use the chat box if they have any questions or comments, and we're going to go over them at the end of the webinar. Our next speaker is Dr. Aws Alherbish. He's a cardiac intensivist at King Saud Medical City and University of Alberta. He's going to talk about temporary MCS devices and troubleshooting at the bedside. Aws, the floor is yours.
Thank you very much, Ahmed. And I would like to thank the panel for inviting me, and I would like to thank the attendees for making it tonight. You guys hear me, right?
Yes.
Okay. Okay. So I have enjoyed the previous lectures quite a bit, and I have to say that I have some overlap with Dr. Stainback's lecture, but I'll try to go fast over those overlaps and cover the new stuff. Okay, so mechanical circulatory support. We're going to go through the temporary mechanical circulatory support. So we will go over ECMO, and on the left side of this slide, you can see a pump and oxygenator of a CardioHelp brand ECMO where they are attached to each other. In the middle, you have a BiVAD system where you have 2 pumps without oxygenators here. The deoxygenated blood is for an RVAD, and the oxygenated blood is for the LVAD. You can, of course, add an oxygenator if you desire to the system, and the oxygenator usually goes to the RVAD side of things, not to the LVAD side of things. On the right side, here you have an Impella, which Dr. Stainback had talked about a couple of minutes ago. So the echocardiography is a cornerstone in the assessment of all those devices. And the objectives of this talk is we're gonna go through Impella positioning quickly. We've talked about it a little bit in the previous lecture, and then ECMO cannulation, which we have also covered a little bit in the previous lecture. Then I would like to show you some complications during the run of those devices. Complications might arise where you need TEE or echocardiography to find out those complications and deal with them. And then the last part of my lecture would be on ramp studies, or how to decide if you're ready to come off pumps. So for Impella, echo is key in telling that Impella is in a good position. And a good position Impella is important to prevent the most common complications with Impella, which are hemolysis and device thrombosis. So your friend image is parasternal long axis view in transthoracic echo. And if you have a good parasternal long axis view, you'll be able to tell if your Impella is well positioned. What you want to see a free inlet, a free outlet, and a free inlet by definition is 3.5 is your teardrop, which is the hyperechoic area in your Impella device, has to be 3.5 centimeter from your annulus, away from the mitral valve apparatus, which can cause blockages and interference with the blood flow. Your outlet, you want your outlet in the aortic root or ascending aorta, above the aortic valve, and you want free flow as well. So Impella, so echo is key. We usually do echo every day, and we try to acquire a good paraternal axis view when we have an Impella device. Now, when it's time to try to come off Impellas, all you have to do is go to a low P level. Usually we go to a P level 2 or with low flow, and then assess your left ventricular contractility to decide if it's time to come off Impella. So I have 3 examples here from our center. So this is a well-positioned Impella, where you can see that the teardrop is about 3.5 centimeters from the aortic annulus, and you can see a free inflow port. So this is an example of a deep-seated Impella, and you can see that the Impella here, the teardrop is very close to the mitral valve apparatus, and this, as I said, can cause problems with flowing, can cause hemolysis, and even device thrombosis. Even worse is a very high Impella, where you can here see that even the position is not stable. There is some rocking motion, and dislodgement could happen with this positioning, as well as hemolysis and device thrombosis. So you want to avoid that. You want this Impella more in. So enough of Impellas. I'm going to switch gears now to ECMO cannulation, and I'm not going to cover everything. So in VA ECMO, I'm going to go through where you want your drainage cannula in peripheral VA ECMO cannulation to be, and how to guide that. And then in VV, because the single cannula, the Avalon, we've talked about it to start. And number 2 is I find that it's falling off favor nowadays because of the problem of recirculation with the device rotation. So most centers now go with 2 cannulas. So we're going to talk about dual cannulation guidance. So to start, you want to avoid something like this. You want to the first thing that's going to come from your femoral vein is the guide wire. You don't want to see the guide wire going into the RV, and we're all familiar with the guide wire going into the RV. And you see next, you see is the VT on the monitor. So you ask your operator to pull the wire right away. What you want to see is the wire going from IVC to SVC in your bicable view. So it's going, this is a good wire positioning. So in VA ECMO, you want your drainage cannula to come from femoral vein all the way IVC and then all the way to the SVC, and set nicely like this in the SVC, which will make it stable in a good position, and you will have ports draining from the SVC area as well as from the RA or IVC area. So, and then you will be able to flow high and be happy. So that's what you want to see in VA ECMO. You want to see your cannula coming from IVC all the way toward the SVC. In VV ECMO, where you have 2 cannulas, you don't want them too close, as Dr. Stainback had covered. You will have a recirculation problem. We don't want them too far, where you start to have suction events because of your drainage cannula being in the abdominal aorta. So you want them in the middle. So what you want to see that your return cannula here coming from the IJ to the SVC in the mid SVC. So this is a good positioning of the return SVC return cannula. Your drainage cannula, so this is a TEE image of the IVC. All you have to do is go to the gastric window, and then with 70 degrees rotate to the right, extreme rotation, and you will have your IVC. It's not a conventional echo window, I know, but we do it to look at the IVC all the time. So you want your cannula sitting like this. You don't want it too low where you will have suction events. You don't want it too high where you could have recirculation. Okay, so enough of guiding ECMO. We talked about Impella and guiding the ECMO. So we'll go through to complications. While you have ECMO running or Centrimag BiVATs or LVAD or RVAD, you can run into complications. So it's not a complication, but one of the things that can happen is suction events. So suction events means that you have too much negative pressure on the drainage side of things, when you cannot flow adequate because of the suction events. So causes of suction events are the ones that you have here. Preload, you're dry, you need volume. Too much RPMs, you need to dial down. That your patient is moving too much and causing too much abdominal pressure, so is not sedated. You need sedation or even paralysis, or anatomical problem. The cannula has a problem position-wise. So it's not a surprise that echo can tell you about 2 of those things. It can tell you about the preload conditions, as well as it can tell you about the cannula position. So when you have recurrent suction events, echo is key in telling you what's causing suction events. So That's number one. Number two is that tamponade, it's the most annoying and a very common complication that happens with ECMO. So echo is key in telling you that you have tamponade or a major bleeding, like a hemothorax or a major bleeding episode. Number three is cardioembolic events or cardiac thrombosis, especially with prosthetic valves, but can also happen with native valves as well as just inside the heart. We once had a complete cardiac thrombosis, and it was catastrophic, and the patient died. We withdraw life support immediately. So you want to avoid that with heparinization as well as with flowing high in the beginning until your heparin kicks in. So showing you some complications here. Here you see some transthoracic and TE views of a loculated pericardial effusion that's causing too much pressure on the right atrium, and the patient, and you see the cannula above that, so the patient will have suction events in this scenario. So on ECMO, usually with tamponade, you have more suction events than hypotension and shock. You start with having suction events, and then so you'll have to do a TE to make sure that you don't have a tamponade. So some tamponade is caused by loculated clots rather than free fluid or pericardial effusion. And in this example, you have a mass, a pericardial mass, compressing the right atrium almost completely, and the patient had significant suction events in this case. Some people will sometimes, I remember in this case, my fellow challenged me, said, how do you know this is not inside the right atrium? How do you know it's compressing from outside? Well, number one is common things being common. This is pericardial compressing extrinsically, not intrinsic. Number two, you all can see a hyperechoic rim surrounding the mass, telling you that that's the right atrial wall rather than an intrinsic mass. This is an example of ongoing suction events, and when we did echoes, we found that the tip of the cannula has a clot on it. So the tip of the cannula started to clot, and in this scenario, we had to change the cannula. So we had to insert a new drainage cannula and remove this cannula that has a clot on its tip. We had also cases where the eustachian valve was actually blocking. So the cannula had to be pulled because the eustachian valve was flapping and unlocking the drainage cannula. This is an example of drainage cannula that had migrated and went right on the septum. So no wonder that this patient had ongoing suction events until this cannula was repositioned as well. Tamponade can also be from loculated thrombus around the left atrium rather than the right atrium, like in this case. In this case, to be honest, when I did this echo, I was like, well, where are we? Like, what view is this? So here's the LV. This is an LA that is like a slit, and you see a huge mass in the pericardium as well as in the pleural cavity compressing the left atrium almost completely. The other complication that we talked about, in this case, it was a COVID myocarditis during COVID, cardiogenic shock during COVID. This patient was on the ECMO, and he was ejecting well, so that we didn't put a vent because he was ejecting well, but then his ejection decreased the next day. When we did a TE, we found out that the right coronary cusp of the aortic valve had thrombosed, as you can see here, and it was, the thrombus was restricting the leaflet motion and had decreased ejection. Okay, so the last part of this lecture will be ramp studies or trying to come off pump. So when it's time to come off ECMO, what we do is a ramp study. So what is a ramp study? In ramp studies, we decrease flow gradually, and then we look at our hemodynamic and echocardiographic parameters with or without inotropic escalation to decide if we can come off ECMO. So why do we do ramp study? Why don't we just drop the flow and see what happens? Because we know that the ventricle will not show its face until you fill it. If you don't fill the ventricle, it's not gonna, you cannot assess the ventricle. So you have to cut down the flow quite a bit. We go all the way to 1 liter, but we don't stay too long in 1 liter to see how is the RV as well as the LV gonna behave when they are filled. And it's very important to remember that successful ramp is good at predicting short-term success, but not intermediate term success. So in other words, many patients that would decided that the ramp was successful and we're going to decannulate had eventually died in hospital, right? So about 40 to 50% of those patients eventually die in hospital, even after successful decannulation. And that's just the sad reality of ECMO. So when do we do ramp studies? You can do it on VA ECMO, Centromag LVAD, Centromag RVAD, or Centromag BiVAD. It's very important to remember that VV ECMO, you don't have to do a ramp. All you have to do is to cut your sweep gas off, or what we call capping. You cap the circuit, and then you depend on the lung to oxygenate completely. So we like our patients to be fully heparinized. You can do TTE, but usually TE gives better quality images. You want to be on the same plane when you compare flow to flow. So you want to compare an apple to an apple. We drop the flow by 1 liter at a time, and we give it about 30 seconds for the ventricle to fill. We don't stay below 2 liters for too long. And of course, if the patient becomes hypotensive or if the hemodynamics becomes unfavorable, we abort the study. So what do we look for when we do our ramp studies? We look for, hemodynamically, we look at our map. You want to make sure that the map doesn't drop. Pulse pressure is even more important. You want to see a good difference between your systolic and diastolic blood pressure while you're cutting down the flow. And the CVP, you don't want to go, you don't want to see the CVP going up. Or in other words, you want your heart to be handling the flow. So echo parameters, the highlighted ones are the important ones. You want to make sure that your ventricles, the LV as well as the RV, do not dilate, right? So if your ventricle can handle volume, your ventricle has to stay the same volume or even shrink a little bit. It should not dilate. You want to assess your global systolic function, and in literature, global EF above 25% is good, it means success. In my opinion, it should be above 30%, to be honest. You want to do an LVT VTI as a surrogate for your stroke volume, assess your regional wall motion, and assess your aortic valve opening with every stage. Right ventricle, to be honest, right ventricular size is important, and septal shift is important in telling that you might fail. So if you get dilated RV or septal shift, that tells you that you are probably going to fail. You cannot decannulate. Until recently, so you can do your TAPSE, S prime, RVSP, of course, and global systolic function. Until recently, we thought that there isn't something that can tell us that the RV, even if the RV doesn't fail, that we might still fail with the RV behaving well, until we had this study that looked at coupling the contractility parameters with the afterload parameters. So what you have to do, you can do your tissue Doppler S prime or M-mode TAPSE and divide that by your RVSP. And then, for example, if you have an S prime above 10 and RVSP below 30, then you are above 0.33. So that means good, that means success, right? So that is a good prediction at having success ramping. I'm gonna go through examples, I guess, if I have time. Do I have time, Ahmed, to go through some cases, or? Yeah, you have 2 minutes, 5 minutes, okay, 3 minutes. Okay, so some real-time cases, so that we don't bore you so much. So from real life, from that I did. So 60-year-old male, inferior STEMI with RV infarct, had RCA stented in the cath lab, peripheral VA ECMO was inserted with no vent because the patient was ejecting on 3rd day. So here we go, you have the patient flowing 4 liters on epi and DOP. Your RV is decompressed because you're on full flow, so I'm not interested yet until I see how the RV is going to behave when I cut down the flow. So this is your LV. You can see the inferior wall is akinetic, the anterior wall is moving. Your aortic valve is not opening because there is no ejection. So we cut down, and that's your gastric short axis view. You can see the inferior wall, again, is akinetic. EF is not too bad, but that's on full flow. So we cut down the flow to 1.5 liters. We're on the same amount of epi and DOP, and you can see that the RV here did not dilate. So it remained the same size, and it has a reasonable function. I would say mild to moderate hypokinesis. EF had improved quite a bit. The aortic valve now opens briskly with every beat, which is good. And our global EF is around 35%, I would say, so it's not too bad. So our decision was to decannulate. So that's case number 1. Case number 2, 45-year-old lady, MVR tissue, AVR tissue for endocarditis, long bypass time, poor tissue quality, bleeding. So no surprise, RV failure post-pump. Failed coming off pump multiple times, so central VA ECMO was inserted with a pulmonary vein vent. So on day number 4, when we cut down the flow, there's only a single image here. You can see that the septum shifted to the left, and you can see that the right ventricle is dilated. So with poor function, we decided that we will have to wait and optimize with diuresis, inotropes, and more time so that the RV recover further. So case 3 is a BIVAD, and that will be my last case, Ahmed. Just give me 30 seconds here. So 55-year-old lady, rheumatic heart disease with severe pulmonary hypertension, came in cardiogenic shock due to AFib storms and severe biventricular dysfunction, got her MVR tissue and tricuspid valve repair, came on VA ECMO, no surprise, with her pre-existing biventricular dysfunction, transitioned after a week to Centrimag BIVAD because she couldn't come off ECMO. So 2 weeks later, that's 3 weeks from her surgery on a BIVAD system. So you have your LVAD at 4 liters, you have your RVAD at 3.5 liters here, and our RVAD has always have to flow lower than the LVAD, only on norepinephrine with good blood pressure. You can see that the septum is midline, the RV is severely hypokinetic, and the LV is difficult to assess on full flow. So you can see that the aortic valve opens with every other beat, not with every beat here because you're on full flow. There is not much of MR with our tissue MVR. So we cut down the flow all the way to 2 liters on the LVAD, 1.5 liters on the RVAD. And you can see here that the RV had remained the same pretty much. So it didn't distend. The septum is still midline. RV is still moderate to severely hypokinetic, but it didn't change much. And then the LV is not too bad. So, you know, it's a gray zone. And you can see, so it's a gray zone area. We decided to go ahead and decannulate and see what happens in this case. We did decannulate and the patient did fine. So there was BIVAD decannulation. With this, I think I'll have to finish because of the time. So I would like to thank you so much.
Thank you, Dr. Aws, for that really, really informative talk. Really great cases. Our next speaker is going to be Dr. Mohammed Chamsi Pasha. He's a consultant cardiologist and multimodality cardiac imager at Houston Methodist Hospital in Houston, Texas. So he's going to be speaking to us on the role of multimodality imaging in assessment of mechanical circulatory support. So without much ado, Dr. Pasha, you can go ahead.
Assalamu alaikum wa rahmatullah jami'an. Can you hear me well? Are you guys able to hear me well?
Yes.
All right. So really, thank you so much, Dr. Rowa Attar, for the kind introduction and the kind invitation. And it's really a pleasure to be among an esteemed colleagues and really masterful talks. In the next 20 minutes, my job is to talk about imaging and mechanical circulatory support, particularly using using CAT scans in left ventricular assist device. So the outline of the talk, we're going to be discussing very briefly about the contemporary use of durable left ventricular assist device, cardiac CT scan, why do we need it, when do we need it, and then what are the things that we're looking for and how do we image those patients, and then the applications of cardiac CT in detecting LVAD complications and functional assessment. As Dr. Stainback kindly mentioned, that the update is coming out later this year, and there will be basically an increasing role of cardiac CT, looking at inflow cannula position, outflow tract kink and twist, thrombus formation, both either at the pump, the cannula, or the aortic root, functional assessment, both the LV and the RV, and also pericardial pathologies. And then we're going to finish by talking about the role of cardiac PET in detecting left ventricular assist device infections. So you guys have seen this before between the HeartMate 2 and the HeartMate 3. We're not going to belabor it, but these are the two centrifugal devices that we have. And now the only one that is available in the market is HeartMate 3. And just to give you a perspective, in 2019, over 3,000 LVADs were implanted, which is really the highest annual volume. This is basically the figure that you guys have seen more than once, the HeartMate 3, and that's the one that got approved in 2018 as an intrathoracic intrapericardial pump. It does have a fully magnetically levitated motor, and it also has a centrifugal pump rotor in order to allow for artificial pulsatility and large blood flow pathways. And now, as we said, it accounts for 80% of the implanted devices. So the role of imaging in selecting and managing patients with left ventricular assist device is fundamental. You want to be able to image the device, the peripheral system, including the inflow cannula, the rotor, the outflow graft, the drive line, all of which are clinically important. And although there's an emerging role for cardiac CT, echocardiography would still be the first line imaging for hemodynamic assessments. So in brief comparison, cardiac CT versus echocardiography in LVAD assessment, the cardiac CT will give you a wide three-dimensional view of the heart with an unrestricted field of view. It has a much higher spatial resolution down to the 0.5 millimeter with excellent isotropic voxels. And it then also can provide functional assessment using retrospective gated acquisitions for both the left ventricle and the right ventricle. Echocardiography, as everyone has spoken about today, really gives you a lot of information about function because of its better temporal resolution, Doppler measurements for filling pressures, mitral regurgitations, and basically it does rely, as Ohoud told us, about an excellent sonographer skills. So these are basically some of the images with a 3D volume rendered imaging. This is going to be the HeartMate 2. This is what a HeartMate 3 would look like, and this is what a HeartWare device would look like using cardiac CT. And as you all know, basically echo would always remain first. This is a patient with sustained ventricular tachycardia supported with a HeartMate 3. Obviously, you're not going to take this patient to do a cardiac CT, and you could actually identify an aortic root thrombus on this patient, but it's still actually viable and will remain the first line imaging modality. So the CT protocols, basically, we start with a non-contrast CT because this can help us assess the position of the inflow, outflow cannulas, kinking if present. And this is usually followed by a IV contrast in order to enhance the arterial system, which is technically the left side of the heart. We always want to use electrocardiographic gated images in order to avoid imaging artifact. And retrospective gating, what it means is that we cover the entire cardiac cycles from 0% to 100%. And this basically provides us accurate functional assessment of the LV and the RV. Be cognizant about the radiation dose with CT, since it does carry ionizing radiation. And we also have metal artifact reduction post-processing filters that can be applied. Now, in this paper that was recently published in JCCT, looking at 58 patients, all with suspected left ventricular assist device dysfunction, they basically compared transthoracic echo and CT with complications later confirmed by either surgical evaluation and or pathology. There were 43 patients, so 74% of the complications were identified. Thrombus or intimal hyperplasia was the most common one, and cardiac CT identified it more frequently than echo alone, 59% versus 22%. This orange bar is the cardiac CT detecting complications. So all LVAD complications were more likely to be detected by CT. We talked about the thrombus. Dynamic inflow obstruction was not that significant because of the superior temporal resolution of echo. Device infection and fixed outflow obstruction was more likely to be detected by CT. And you can find basically that using both methods, cardiac CT and echocardiography, you can improve your sensitivity and specificity with a high diagnostic accuracy. These are the mechanical complications post-ventricular assist device, and we're going to talk about each one of them in the next coming minutes. When we talk about the LVAD inflow cannula, this has to be implanted at the true apex, and it should be parallel to the ventricular septum and directed toward the mitral valve. If the inflow cannula is malpositioned, this basically could be suspected whenever you have low flow alarms or patients with suspected pump thrombosis, patients presenting with ventricular arrhythmias or unexplained suction events. So these are basically images on cardiac CT where you can see the inflow cannula. You can see here the left ventricle, and this is the mitral valve. And you could see that the inflow cannula has to be in parallel to the mitral annulus. Notice this inflow cannula, which is actually directed all towards the interventricular septum and far away from the mitral annulus. And notice about this patient over here who has a very high angle where the inflow cannula is not inserted in the LV apex, but instead it's actually almost inserted in the RV apex. So the off-axis angle greater than 18 degrees in one paper has been associated with pump thrombosis. Notice the inflow cannula angle over here was almost 60 degrees in this case. This is basically a retrospective gated cardiac CT. So think about this on echo as a two-chamber view. This is the left atrium. This is the left ventricle. This is the anterior wall. This is the inferior wall. This is a patient with a heart mate 3. And notice how the inflow cannula is in close proximity to the base of the papillary muscle, while the angle of the inflow cannula looks favorable, as we can see here, with an angle less than 18 degrees. But this patient actually did present with suction events because you can see the pap muscle being pulled in by the LVAD inflow cannula. We can have a beautiful visualization of the outflow cannula. Here's the ascending aorta and cardiac CT. Here's the outflow cannula. And you could actually appreciate here what a normal position with lack of any air, thrombus, or kinking versus this patient who actually has evidence of biodebris in the outflow cannula. And this last patient over here who all has a significant, not only biodebris, but there is a significant kink within this outflow cannula. What happened with this patient is that he was taken to the operating room, and after lengthening the outflow cannula, his flows on this LVAD has increased from 2 liters to 6 liters per minute. So a significant increase in the flow noted in this case. This is basically a case presented a JACC case report showing a left ventricular out-cyst device outflow cannula obstruction noted here on cardiac CT. This is a 2-dimensional image. This is a 3-dimensional image, and you can see the velocities way above the 2 meters per second with a peak velocity of 3.5 meters per second, indicative of significant outflow obstruction. This one here is basically a curved planar reformat of the outflow graft, and what you can see in this case, there is a very hyperacute bend in this outflow graft, almost creating an S-shaped configuration. So for orientation, this is going to be the ascending aorta, and this is going to be basically the graft coming out and inserted into the ascending aorta. And this is basically a significant kink or a bend in the outflow graft. This is a patient actually where you can see there is a significant increase. Initially, what was thought to be a biodebris in this outflow cannula. So this is RV, RA, this is the outflow cannula. With repeat imaging, notice how he has a more irregular shaped and more hypoattenuation affecting the outflow cannula, suggestive of outflow cannula thrombus. Thrombosis can occur at the inlet of the inflow cannula. It can occur in the pump. Unfortunately, we do not have access to see this with the CT, which is the most common location, or it can occur in the outflow cannula, as you can see on this case. This is a patient. What we're doing here is a cross-sectional imaging on cardiac CT. So these are the lungs. You could see over here the outflow cannula coming in plane. This is going to be the ascending aorta. Here's going to be the outflow graft inserted into the ascending aorta, as you can see here on my mouse. And you could see actually that there is accumulation or intimal hyperplasia and early thrombus formation, as you can see basically on this image. We could nicely see that the inflow cannula on this patient is actually free from any thrombus or kinking. This is the same patient, but actually using a sagittal reorientation. So you could see actually the outflow graft here inserted into the ascending aorta, and it really appears to be patent. But this is the patient who actually did have evidence of thrombosis in the outflow cannula, as you can see actually right over here. So this is basically what the 2D image looks like. The outflow cannula basically was chock loaded with thrombus in this patient who presented with suspected VAD thrombosis. Now, aortic regurgitation is actually, as prior speakers have alluded to, that with continuously closed aortic valves, these are usually exposed to high pressure gradients. And the new onset aortic regurgitation can be seen in 1/3 of patients 1 year after left ventricular assist device, and it's a bad prognostic marker. This was a recent CT of a patient that I've read their CT of, and what you can see here, he has a very large sinuses, and his aortic valve, what we notice here is this is the right cusp, the left cusp, and the non-coronary cusp. During diastole, it does not close. So notice how he has a large coaptation gap. And not only that, but his also aortic annulus was actually significantly dilated. He had significant aortic regurgitation, as you can see here, with a continuous flow aortic regurgitation. He was not a candidate for TAVR because of the fact that his aortic annulus was significantly dilated. And really, the future should hold of developing these prosthetic valves for treating aortic regurgitations and mildly calcified valves is still a work in progress. This is a 43-year-old patient with stroke post-HeartMate 3. This is going to be an aortic thrombus, which is noted over the right coronary cusp. This is going to be the left. This is going to be the non-coronary cusp. So there is a large area of hypodensity consistent with aortic root thrombus. And this is unfortunately an under-recognized and devastating complication because it can be associated with multiple events, stroke, MI, failure, and ventricular arrhythmias. This is another case where the root thrombus was actually extensive, and it was actually involving the origin of the right coronary artery, as you can see here, and basically causing extensive thrombosis at an inferior STEMI in a patient supported with left ventricular assist device. Now, do LV recover with ventricular assist device? Yes, around 5% of patients can have left ventricular assist device, native left ventricular functional recovery. So this is a patient supported with a ventricular assist device, has normal LV, normal RV function. This is, again, the patient with 3D volume rendered images. And this is what it looks like on a two-chamber view. Despite the fact that the VAD actually was not well aligned, the patient actually has had good functional recovery. In one paper, which was the restage heart failure, they actually have reported close to 50% LVAD explantation to achieve an end-diastolic diameter less than 6 centimeter and an MR less than 2+, but really needing aggressive pharmacological therapy. Pericardial tamponade, what we see over here is the LV, the RV. There is a large pericardial collection and a very thickened pericardium, as you can see here. But remember that even loculated and small effusions can cause significant tamponade without significant evidence on echocardiography. This is the outflow cannula noted on this patient. The RV size and systolic function using CT can be accurately assessed. Notice here the normal RV size, but notice how the significant RV dysfunction is noted with basically poor RV contractile reserve in this patient who's also supported with a left ventricular assist device. Now, moving on to the device-related infections, which is one of the common frequent adverse effects seen in 1/3 of patients. 18% can occur during the first year after implantation and almost 12% the years after. This can involve the drive line, which is the most common location. We're going to show you the picture where the drive line is. It can also involve the pocket and or the pump and inflow or outflow cannula. The most common organisms are going to be the Staphylococcus aureus, the coagulase negative staph, and basically the gram-negative rods. The clinical presentation in those patients who have no identifiable source, but they have either persistent bacteremia, fungemia, or fever of unknown origin, and also you should suspect it in patients who have unexplained embolic phenomenon. The role of the fluorodeoxyglucose PET imaging is that the inflammatory cells really have an increased glucose metabolism and they concentrate glucose. So using FDG combined with positron emission tomography is a very sensitive and specific and an accurate test for diagnosing infection. The protocol with this slide shared by Dr. Aws Alherbish is usually the day before we actually have the patient on a low carb, high fat diet with fasting for close to 12 hours because we need to suppress the myocardial glucose uptake. And then basically at the test day, they are injected with heparin. Then basically they're injected with FDG, and then you acquire your fluorodeoxyglucose imaging an hour after. It has already been incorporated in the European Society of Cardiology guidelines, and its diagnostic value for this indication is supported by an extensive body of evidence. In this meta-analysis of 10 studies, 230 patients, the sensitivity for VAD infections was almost approaching 90+%, along with an excellent specificity. In this contemporary meta-analysis, we can see basically that the combined sensitivity and specificity is also excellent in 92% for sensitivity and 83% for specificity. This is basically a HeartMate 2, and we could actually see the pump rotor. We could also basically see here the drive line. And this is basically a patient who has a increase FDG uptake across the drive line. And we can actually see this on the sagittal image. We could also see this on the axial image. You could also develop an infection at the outflow pocket site. So this is here is the ascending aorta. This is the pulmonary artery, and you can see here there is an increase uptake of the FDG on these PET-CT fused images. This is basically what it looks like on the axial images, and really kind of the pattern of the uptake has to be more of the diffuse, heterogeneous, as you can see here, diffuse, but it has actually more than one foci, one location, with an intense tracer uptake that's usually going to be persistent on both the attenuation correction imaging and the non-attenuation correction imaging, because artifacts can actually make things worse. This is basically another evidence of an increased FDG uptake in this patient at the driveline entry point. And we do see this figure here of SUV, which basically stands for standardized uptake value. And the standardized uptake value is a measure of intensity compared to background. And what basically the literature has suggested that if your SUV is 3.8 or more, it has a high sensitivity and specificity for diagnosing infection, almost approaching 100%. This is another patient basically who on the fused PET-CT images, you see everything here that's lighting up. You have a very diffuse, a very intense tracer uptake by FDG, and it's actually involving not only the drive line, as you can see here, but it's actually involving the outflow graft. The whole outflow cannula graft actually has evidence of infection. Notice how there is no evidence of FDG uptake near the pacemaker site, and that is basically what you can see on these large field of view images. This is a patient who presented with a very large collection in front of the outflow cannula. These are the coronal images, these are the sagittal images, and this is the fused image with the FDG PET. Again, a very diffuse and a very homogeneous intense tracer uptake consistent with a ventricular assist device infection. Notice that false positives can occur, especially in the first few weeks after surgery. Non-infectious inflammatory cells can basically cause an FDG uptake. Vasculitis could also cause that. And that's why we always use our imaging both with attenuation correction and non-attenuation correction, because if I use the attenuation correction imaging, this can create artifacts around pieces of metal. If antibiotics are being used before imaging, this can cause a false negative study. LVAD infection and outcomes based on this paper published 2 years ago, you could see basically that patients who have central infection in red have a much worse prognosis compared to peripheral infection based on these survival curves. And I'm going to finish with this case over here, the patient who had a HeartMate 2 destination therapy. He was admitted with group B strep and ophthalmitis and brain bleed. And what you can see basically over here, here's the ascending aorta. And right at the anastomosis side between the outflow graft and the ascending aorta, there is a very large heterogeneous complex fluid collection anteriorly. And not only that, but there is contrast seeping in through this area. Notice how there is contrast going in with a potential left ventricular assist device leak. And this patient actually had an FDG PET, and you can actually see here the inflow and the outflow cannula. Basically, there is a very intense tracer uptake, almost diffuse enough that's actually covering the entire ventricular assist device. And not only that, but this was the area of the collection around the outflow tract and graft anastomosis. And this was basically highly consistent with an infection, giving a standardized uptake value of 9.5 with a threshold of 4 being significant. So ladies and gentlemen, take-home points from this talk is that 60% of patients with VAD will develop complications in the first year. Using cardiac CT as an adjunctive tool to echo has a unique ability to identify anatomical, structural, and functional complications. And LVAD-related infections do carry a high morbidity and mortality, and early identification with FDG allows for accurate diagnosis and early initiation of treatment. These are some resources that basically are available for everyone to use, and I thank you all for your attention.
Thank you, Dr. Pasha, for this great presentation. I just would like to remind the attendee, if they have any questions, they can go ahead and use the chat box. I can start with my first question to Dr. Stainback. So because you focus more in the right ventricular function, my question to you is like which marker or what parameter that you are using to predict RV failure post like a durable LVAD implantation? Is it more TAPSI? Is it more the RV strain? As a combination of everything, which one do you find is the best?
Well, like I said earlier, the Achilles heel of LVAD, you know, and I assume you're talking about the durable support VADs when somebody gets an RVAD. So it's kind of we sort of have failure to wean from bypass, so acute RV failure right after the LVAD goes in where we need support there. Or we can have LVAD failure first 14 days of after implant, they're inotropic support dependent. Sometimes that can clear on its own, or you get late failure where you have to actually intervene. A lot of these patients we can just bridge pharmacologically, but we found that if you know, it's a clinical diagnosis and the echo plays a supportive role. So after the LVAD's in and we're doing what I'd call an optimization study. The patient's got low flows, they're in heart failure. The first step is to make sure they don't have persistent LV failure. And so you turn the device up, sometimes they get better, but then when you turn the device up and the RV gets overloaded, then you see this combination of high RAP, the RV is dilated, or we can't increase the flows, then you're really sort of stuck. And in those patients, you've got the choice, really, you're not going to do VA ECMO necessarily in those patients, but we're using more the Protect Duo, really. It's got a few advantages. I think we like to use there's the Impella RP Flex that's newer, and it can be put in through the right IJ, so the patient can like walk around a little bit better. We've used it in a few patients, but it's a device that has it clots a little bit more easily, and so I think our preference really is using the Protect Duo more and more. It's unfortunately that's pretty aggressive support. I don't know, what do you guys any other comments on this from the other practitioners? Let's see,
Maybe Dr. Aws?
Yeah.
Yeah.
Sorry, I wasn't, I was a bit busy with that. What was it?
The question was, yeah, after LVAD support and you've got RV failure after,
right,
kind of, I guess in the early post-operative period, what would be your preferred method? I mean, preferred is not to use the device, but if you have to.
Yeah, ouch. Yeah, that's it's a difficult, it's our nightmare, right? In CVICU, like they come and that's what will give me a tummy ache overnight, is the idea that the RV is failing on me. That's why we like Swangans and all those people, and we like to avoid giving them so much volume. We don't want the RV to distend. We want to keep them dry. And so, but I guess no matter what we do, about, I don't know, 10-20% of those people will end up having an RVAD, a Centrimag RVAD, I guess, at some point. And then the question is what's going to come after that. So when we put an RVAD in, we know that it's going to be weeks. It's not going to be days by all means, right? So it's going to be a slow training to that right ventricle, to the new, I guess, physiology, and a lot of milrinone and sildenafil at some point, and slow weaning and keeping them dry, and CRRT, and hoping that RV is going to behave itself. I guess the eventual, if the RV does not recover, you're stuck with a transplant. And if they're not transplant candidates, you're in trouble. The two patients I remember that we tried and a durable RVAD on had died. They did not survive.
Yeah, I didn't mention that we, you know, if they're really unable to wean from bypass, the surgeon, and just as an imager and a heart failure doctor, we sort of just get what comes out. We image what I've seen is we've done HVAD heart mate 3 in the RV position, like putting a durable VAD there, and also the Centromag that, as you mentioned, that's an option because the patient can lie there. It's femoral access. We've used the Protect Duo less often, the RP Flex, just because it's a little, it tends to clot a little bit easier than some of the other devices. So it's tough. Yeah.
It is.
Yeah.
We have a follow-up question from the audience. Someone's asking if Dr. Aws can elaborate how a Swan-Ganz assessment is useful for assessment of RV failure.
So HeartMate 3, heart transplant and HeartMate 3 for me are the few, there are few scenarios where I would insist on a Swan-Ganz. I wouldn't insist on a Swan-Ganz with other cardiac surgeries and other cases. And the reason is the RV is probably most sensitive in those two scenarios, in a HeartMate 3 and in a heart transplant. So those are and the reason is why is that? Because those patients are extremely inflamed, they're vasoplegic, they need a lot of volume in the first couple of hours. Sometimes we resuscitate them with 4, 5, even 6 liters of fluid, and that's what exactly the RV hates, right? So you're gonna distend that RV, and you have no option because of their vasoplegia and inflamed distributive shock. And the question is, you want to restrict how much you give them, and you want to be up on your inotropes, and you want to keep your filling pressures low. Sure enough, but without a Swan, that's really tough, right? Without a PA catheter, that's really tough. So sure, I sometimes in those patients, if I don't have a PA catheter and I don't have the time to put a PA catheter, I would leave the TE probe in. I will put the TE probe and leave it in, right? I'll just freeze the image so that the probe doesn't heat, go and see the other patients, come back and give them a liter of fluid and turn my TE on again and see where are things, where is the septum sitting, how distended the RV is the RV still happy or not. Those patients are very, very fragile, and sometimes just a couple of more liters and then the RV fail on you, and then you're in trouble. So that's why I like a Swan, because I would like to try to avoid how much volume I give them. I would like to go up on my pressors if they're distributive more, rather than giving them more volume, and use my inotropes effectively as well. I hope that answers the question.
Okay, we have another question. This is to Dr. Fahmy. It's a big question, but if you can answer it in 1 minute. What is the outcome of temporary MCS and cardiogenic shock, especially in reducing mortality? Dr. Fahmy?
I think she's.
Sorry, Dr. Ahmed, I can't hear the question clearly.
Okay, so what is the outcome of temporary MCS and cardiogenic shock, especially in reducing mortality?
Yeah, this is actually a very big question, as you mentioned, Dr. Ahmed. Actually, this will depend on many factors, especially what's the cause of cardiogenic shock. This is a patient who we know is chronic dilated cardiomyopathy with severe reduced and advanced. You have shown some symptoms of advanced heart failure, like Intermax 5 to 7 days patient. So we know he's chronic, and when he shook this patient, that's mean really the mortality is very high. And now the MCS maybe will be more challenging to improve or get the patient out from this this shock. On the other hand, we have some group which show this good response, like patient who have acute myocarditis, patient with peripartum cardiomyopathy, sometime to the limit with acute MI with good rapid revascularization and on call. Yeah, this group of patients we expect actually to have good response, and usually you can give him your time and wait and usually don't go for something durable until be clear. This is not respond this group of patients. So it depends usually in the subgroup. It's not clear for one group. You can't give one data for all group of shock, especially cardiogenic shock. Usually there's subgroup which you will have different response.
Okay, another.
We have time for one last question. So, Dr. Fahmy, I think you had a question for Dr. Pasha.
Yeah, yes, please,
Follow
thank
up
you.
with action.
So for Dr. Pasha, yeah, just quickly, for the it's a good presentation and great presentation actually, and you are focusing mainly about the diagnosis. My question about the after diagnosis, especially the infection of fat, how can this PET or CT help us to have further management, like duration of antibiotic, or to some extent we said this failed antibiotic and we should go for the next step, like change the drive line, exit, or explosion. So can PET scan and help us, or CT scan and PET scan help us to make this decision?
That's a very practical question. I think one of the audience was also trying to see when is the timing of getting a PET CT scan after a ventricular assist device. Unfortunately, there is no consensus, but most of the experts suggest that the first 3 months after a complicated surgery can carry a false positive FDG uptake. And that's probably because of all the surgical bioglue that are being used, but also the in situ inflammation. Now, the question is, how does imaging guide management? Is number one, we have seen from the outcomes trials that if you have a central infection versus a peripheral driveline infection, people are going to do worse. So these are the people that would basically need an early initiation and discussion, especially if they are bridge to transplants, or whether or not they should be listed. The other thing that also the every PET scan basically has a built-in CAT scan, meaning that we can actually see an entire field of view, including the upper body from the neck all the way down to the abdomen. And if there are any other potential sites of infection, or if there is any evidence of septic emboli, especially basically these people can have either splenic infarcts, they can also have cerebral infarct. So the extent of the infection, whether or not it's only localized versus it's complicated and it's basically has involved more than one site, like the pacemaker pocket, the inflow, the outflow. I think this is where the PET CT would actually add value in determining whether this is someone that you're going to treat chronically with antibiotics versus someone that would require an exchange of their VAD, or basically an upgrade to a transplant.
Okay, so I really thank everyone for the excellent presentations. Honestly, thank you to all the speakers, and I'd really like to thank the audience for sticking around, depending on which time zone you're at. So here it's pretty late. In other parts of the world, Dr. Pasha and Dr. Stainback are just kind of midday. But really, I really appreciate all the time that you guys put in to make this webinar happen. So thank you so much.
Thank you.
Thank you, everyone.
Thank you.